Hi, this is Ellie Fishman, and welcome back to part 3 of our discussion on cinematic rendering. We're in the middle of looking at applications, so let's take a look at the pancreas. If you think about these three images, it's the same volume data set, but depending on what we're trying to highlight. This is a patient with a tumor in the body of the pancreas with occlusion of the splenic vein and narrowing of the portal vein SMV confluence. You can see many of the collaterals present. On the first image on your left, you can see the bowel really well. On the middle images, you don't see the bowel at all. You see the liver and the liver vascularity, as well as some collaterals in a prominent left gonadal vein. And in the image on your right, I've given you a lot more detail as to the liver as more of a solid organ, and the same thing with the spleen. When we look at the liver, we can do texture mapping. This is a patient, yes, has a fem-fem bypass graft, but look at the liver. Look at the MIP, then look at the 3D rendering of the liver. Look at the detail of the falciform ligament and the texture of the liver surface. I can keep changing the rendering parameters to give you even more detail. Again, structural changes of the liver may be something we can analyze. And again, look how, if you were going to do surgery on the liver, partial hepatectomy, or transplant, or almost anything, how valuable these liver images would be, particularly when I give you the vascular map. In this image, I'm simply changing the lookup table. Here you see the liver surface. You kind of see the vessels, portal vein, SMV. But look at the detail of the hepatic veins that you see as you change the rendering parameters very nicely there. Again, the importance of simply interacting with the data. Another set of images here, collaterals. You see the stomach well. You see varices in the gastric fundus, varices in the retroperitoneum. We change the rendering parameters again to accentuate the vessels a little bit, increasing the shadowing and increasing the information. Here's a patient with sarcoidosis. You see the nodes in the hilar region and subcarinal zone, nicely shown in the axial CTs. When you look at the liver with MIP, you can see that the IVC appears to be compressed. The liver and spleen are enlarged. You see the adenopathy in the mediastinum. But look how much more information we could see as we're going to go from these coronal views with the textural changes, with the differential enhancement proximally and in the periphery of the liver, classic for Budd-Chiari, one of the unusual complications of sarcoidosis. But with the rendering, look at the changes in the texture of the liver and of the spleen, the lobulations. On the cinematic rendering, you see the collateral vessels due to the patient's Budd-Chiari syndrome around the surface of the liver, around the dome of the liver, and in the fissures. You see the lack of visualization of the hepatic veins, but good visualization of the portal vein. Again, the textural mapping from above showing the collaterals. Infinite number of perspectives, but we try to accentuate the information we're showing the user. Speaking of liver, here's a patient with a mass in the tail of the pancreas, calcification. It's a neuroendocrine tumor, and you nicely see the vascular liver lesions consistent with metastatic neuroendocrine tumor to liver. But look at the details with the cinematic rendering, the borders of the lesion, the smaller lesions, the texture of the lesions. You see also in this image on the right, the pancreatic mass with the calcification. So the ability to accentuate, to analyze, to quantify, and detect the presence of liver disease is accentuated when you do this. And you can see it very nicely in this example as well. Now, as you move to the pancreas, here's an example of a normal pancreas, very nicely shown with the cinematic rendering. Look at the spleen. You see the splenic artery and vein entering the spleen. You nicely see the lobulations of the spleen. I can either show you the liver well on the right or just some of the vessels on the left. Again, the textural changes of the pancreas are important because it's our experience to pick up small pancreatic cancers or small neuroendocrine tumors. Changing the texture and optimizing texture mapping may be an ideal way of seeing small tumors. Here's a good look of the texture of the gland, the relationship to the patient's vessels, whether it's GDA, hepatic artery, or SMA. Again, the volume provides substantial information. Think of this if you're a pancreatic surgeon. And here's just a good example where I'm changing the lookup tables, where I'm optimizing the texture of the gland, making everything else very transparent, and then showing you the vascular map as the GDA goes over the region of the neck of the pancreas. The ability to change the texture as I'm doing here and really optimize the visualization becomes critical. Again, I'm going to say that we want to pick up smaller pancreatic tumors. Remember, 40% of tumors 2 cm or less are missed. Well, I want to find those tumors, and I think by doing cinematic rendering, by looking at the earliest textural changes, I'm going to be able to do that. So I think it's very exciting, and you can see it very nicely in this example. Here's another patient, just to give you a little bit more detail. Atrophy of the body and tail of pancreas. There has to be a mass sitting about right here in the mid-body where there's a transition zone. That's a thing we always look for. You can see also the dilated pancreatic duct. So this is a small tumor which is often overlooked. Here it is when you look at the cinematic. Here I'm showing you optimally the patient's arterial structure, celiac and SMA, as well as the splenic vein and portal vein. Now from below, I'm bringing in the pancreatic glandular texture, and I'm looking at that, and I'm looking here at the dilated pancreatic duct. These are the same rendering volumes, but it's how we show the information that will vary. And you can see very nicely when I play with the texture a bit, there's the mass. It's much more obvious here. There's the dilated duct. There's the atrophic distal body and tail of pancreas. Again, a carcinoma of the pancreas. Again, these are the things we do not want to miss. And again, you can see as I go through the coronal display, textural changes showing the relationship, and for preoperative staging is going to be ideal. As you can see, the celiac, hepatic, and splenic here very nicely, the GDA, as well as the SMA. So again, a comprehensive exam showing you arterial and venous structures is what we're able to provide. And you can see here this slight compression of the portal vein SMV confluence and splenic vein confluence. Again, all very important features when you're doing surgical planning. Here's a larger tumor, tail of pancreas, patient presented with gastric outlet obstruction. You can see the tumor is really obstructing the fourth portion of the duodenum near the ligament of Treitz. That's why the patient presented with gastric outlet obstruction. You can see the mass nicely here on the coronal volume rendered images. But I think when you compare the coronal volume rendering and the cinematic rendering gives you a better feeling. You can see the red fluid within the stomach and duodenum and the solid tumor invading and obstructing the duodenum from the primary carcinoma of the tail of the pancreas. So again, looking at the volumes become very, very critical. We published an article, this is by Amar Javad as the first author, talking about cinematic rendering as a tool for improving pancreatic cancer surgical planning. And in this article, it made the point that surgical planning is much more accurate and you decrease inter-observer variability when you create these 3D maps. And that's something we routinely do for our practice. A quote here, cinematic rendering allows for nuanced visualization of areas of interest. Our preliminary observation and experience as one of the first centers to incorporate the routine use of cinematic rendering has proven very useful in surgical planning. I think there's a very good article for you to read. Look at the last statement. CR could help avoid unnecessary surgery by enhanced identification of occult metastatic disease that is otherwise not appreciated on a standard pancreatic protocol CT. So lots of potential advantages. And again, this is something you need to implement into practice. And this article does explain a lot of the things we do and how we use it in our multidisciplinary pancreatic conference. Again, I think one of the things we also talk about are some of the various signs for looking at tumor response, looking at whether a patient is eligible for surgery, this halo sign, which is something that's important as you think about dissection of the SMA. Remember, when patients are not resectable or borderline resectable and they get chemotherapy, they often can become resectable, but you don't want to operate on somebody unless you're going to have an R0 resection. So the cinematic rendering can prove very valuable in that regard. So it's something, I think, here's some good quotes, but I would read the article. That can be very helpful. Another case of a subtle pancreatic cancer that was missed, of course, was missed elsewhere. There's a lesion in the body of the pancreas, the body-tail junction. You see the low-density lesion. You also see the patient's dilated pancreatic duct right there. Here it is with classic volume rendering, and one has to admit you can see it nicely over there as well. There's the duct. There's the tumor. Not a problem. But look at the cinematic rendering. Look how it accentuates the texture changes really nicely there as I range through a variety of presets and parameters. And here it is in a coronal view, a volume rendered coronal view from the front. Just a really nice example of a small pancreatic tumor and vascular staging, as we do as well. And this patient would be a good candidate for surgery. Now, it's not just pancreatic adenocarcinomas. Here's a 1 centimeter mass tail of pancreas, which you can see on the axials and then nicely shown on the cinematics, right? You go from here to here to there's the volume display, really nicely showing you the lesion with a small feeding vessel. And here's another neuroendocrine tumor. This one's larger and it has calcification. I showed you this one to give you a feel about the tumor texture, but also how calcifications look when you do cinematic rendering. And then, of course, here's a case from just recently. Here is a 1 centimeter lesion in the head of the pancreas, very vascular. There it is on a coronal display. That's classic for a neuroendocrine tumor. Here's just some cinematic renderings, beautifully showing you the lesion. There's the GDA. There's some of the vessels going right to that tumor. There's the texture of the tumor changing as I give you a range of renderings. But again, look how nicely you can see a 1 centimeter mass. Now, I'm not saying I couldn't see it on the axials. You could, but I just want to show you how cinematic rendering, depending on the tumor type, will have different rendering characteristics. And this is very nicely shown here as well. And multiple images are generated. I mentioned that I'm coming up with some new rendering techniques. This is for optimizing the detail of the vessel. Look at this 3D render here. There's the GDA. There's the tumor. There's the vessels. Look how sharply you can see the edges of the vessels. I think it's very exciting. This is another neuroendocrine tumor, but it was a cystic peanut. That's less common, but you can see a low-density lesion with rim-like calcification or rim-like enhancement. You see it really nicely on the cinematic rendering. I think it's easier to see on the cinematic rendering than it is on the axial images. So that becomes very important as I go through the data set. At times, you may see a neuroendocrine tumor, which we typically think about arterial phase. You may only see it better on the venous phase. Here was a patient where there's a subtle tumor here. This is the arterial phase. In retrospect, it's there, but it's really subtle. On the venous phase, you actually see it better. So occasionally you will see neuroendocrine tumors better on venous phase imaging. Again, look how subtle the changes are when you look at the coronal imaging of the arterial display as opposed to the venous display. So now I'm going to go do that same case with cinematic. At first glance, the pancreas on arterial phase looks pretty good, but then if you look a little bit more carefully, you see the textural change. And this is a good example of me showing you a case where the lesion is obvious on the cinematic, but was not seen even in retrospect on the arterial phase imaging. The textural changes are accentuated by this technique. And again, here is the arterial and here's the venous. Yes, even here it shows better on the venous than on the arterial, but you see them with both techniques very, very nicely. Okay, really nice example of showing you that. Pancreas really well defined with the neuroendocrine tumor. We've also done work looking at the spleen. Here's a large lymphoma, diffuse infiltration of the spleen, again focusing on the textural changes. And here's really nicely the textural changes as well with the cinematic rendering. Classic for lymphoma, though it is possible to have other possibilities, but again, very nice textural changes. We've also put a lot of work on the stomach. This article by Steve Rowe and a recent article by Claire Brookmeyer talks about cinematic rendering as a way of looking at gastric masses and gastric pathology. CR has tremendous potential in the treatment planning for gastric masses, although its exact role and effect on surgical planning and endoscopy has yet to be delineated. But again, we can do a great job. Look at the detail of the cinematic rendering of the gastric folds. Imagine trying to pick up a small tumor. You should be able to do it if you could accentuate the gastric folds, use water to distend the stomach, use IV contrast, and you have really nice mapping. And so, for example, with the addition of enhanced surface detail intrinsic to cinematic rendering, the role of 3D visualizations in the stomach and stomach neoplasm imaging may be expanded. And I think this indeed will be very exciting. Here's an example of a patient with a pancreatic cancer, but I want to show you the gastric folds. You look at the axial images or coronal, the stomach is not very impressive. But when you open up the stomach and look into it, look how much detail you see. Oh yes, look how nicely you see that 1 centimeter pancreatic cancer. But look at the detail of the gastric folds. This is a normal stomach, but it gives you an idea of what we can do with the gastric folds, and we can show that indeed very, very nicely. Another patient, here's a gastric tumor. This was a 2 centimeter GIST tumor coming off the anterior wall of the stomach, nicely shown on both the sagittal volume rendering and the cinematic rendering. Again, the gastric folds nicely shown cinematic, and the soft tissue mass clearly defined and beautifully shown with this lighting model with the shadowing. Just a really, really nice example. And here's a great unusual case of a duplication cyst. It's a mass, it could be a GIST, but it's water density, so it must be a duplication cyst. Here it is sitting into the stomach. Just a really nice look. Again, the gastric folds. There's the lesion, really well defined. And again, if you're looking at this data set, you could look at it with motion. You could change the shadowing. Look how nicely we're looking in the stomach. So to me, we always talk about how it's hard to pick up subtle gastric cancers because of ulcerations and surface lesions. Well, perhaps this is going to be the way to do it by accentuating the gastric folds and being able to look inside the stomach rather than looking at secondary projections. So I think that's going to be very exciting. Here's a patient with multiple gastric polyps, and this was biopsy-proven adenocarcinoma in the patient's polyps, and you can see it very nicely there. Just a very, very impressive example of very extensive disease. And here's just 4 sets of images cutting through the stomach, showing you all of the polyps and the extent of involvement, very nicely shown. This patient had gastric carcinoid tumors, had MEN1. You can see the polypoid lesions enhancing on the axial views, but look when I go inside the stomach. There are all the polypoid lesions. Here's a sagittal view. There's the gastric folds. Here are all the polypoid lesions very nicely shown. And again, better shown in this image as well. So again, better detail looking at the fold pattern, looking at smaller tumors, looking at texture. Now, other things we can do involve the small and large bowel. But let's do this. Let's stop here. And let's pick up the colon and small bowel when we come back in a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.